Hey guys, Juan here doing another video. This video is on, well, Srna, CRNA student, what we do, what my routine is like, and a few things that come to mind. I know that a lot of you who are registered nurses or completing your RN degree are debating whether, should I do CRNA and P? Should I go for medical school? Well, you know what? A CRNA and an MD or an anesthesiologist, they both work in anesthesia, but CRNAs do not want to be MDs. And this is, if you just go on the internet, you can see like both sides of the arguments. And I really don't want this. I'm not even going to talk about that in this video. That I will save for another video. This video was a video that I needed to make a long time ago, and really that's just like my routine or what to expect as far as clinical goes when you're in the CRNA program. So I'm just going to talk about my schedule at my home site, to give you more an idea of what your duties are as a CRNA student. So you know that it's a job. You're not going to be getting paid for it, but they're training you for the real world. So you report to work. At the cases will start at 7:30, so you should be in the OR at 6:30. First thing you do is you go into the room. Let's just say I have a case in OR. I have OR room 1 for the day, and I have 3-4 cases in that room. I go on in, do an anesthesia machine check, make sure everything's in order. You get your airway equipment, your emergency drugs. You draw up your drugs for that patient that you're about to receive or that you're about to see. So you just make sure your room's ready and everything that you need as far as anesthesia goes is in that room. Case starts at 7:30, so by 7 o'clock you go and you see your patient. Usually some patients come a few days before and they get either lab work done, EKG, either history, HMP is already in the chart, so sometimes you might have already looked at that the day before. If not, you can see it when you go see your patient. Introduce yourself to the patient, start an IV, and after reviewing the chart and see if your anesthesia plan correlates with what you see with the patient, with your assessment. If you need to go back to the room to make any changes, you go and you do that, such as like maybe you have an obese patient and you feel like they need to be ramped, or if you feel like you might have some issues with their airway where you might need a glide scope instead of a direct laryngoscopy for intubation, things like that. You go and you go back to the room and set it up. Once you meet with in the pre-op, you might meet with the anesthesiologist. If not, you might meet with your preceptor. You just let them know, hey, this is my plan, this is what I thought, and they'll either agree, make some changes, or just see how that goes. Sometimes you might even have to discuss things with the surgeon as far as how long they anticipate the case to be, how invasive, what estimated blood loss do they feel, or do they have any issues that you should be aware of. So once you have all that set, a surgeon will come in, you guys will decide on the antibiotic, all consents are signed, everything's good, everything's ready to go. Usually you give a patient 2 milligrams of Versed before going in. So everyone goes into OR room 1, and let me just break down like the team players that are in the OR. There's the anesthesia team, Srna, CRNA, or MDA. There is the OR circulating nurse. She's pretty much the one that makes sure all the paperwork is in order, everyone's ready to roll. There's a surgical team with the surgeon, maybe his PA or NP, and then there's scrub techs that are also help with the surgery. So I like to consider the operative period to be, as far as anesthesia goes, to be induction, the intraoperative period, and then emergence. So once everything's in check, anesthesia goes. Anesthesia's first up, to put the patient to sleep, and that's usually induction. That's where we give our medication. Either you intubate the patient per an airway, depending on the case and the anesthesia that you're going to be giving. Then during the intraoperative period, you have to keep the patient, depending on if they want the patient paralyzed or what the case is. It's the intraoperative period with the surgeons performing surgery. And then there's emergence, which is the waking up, where you're going to be waking the patient up, transferring them to recovery to PACU, and then giving them report, and then signing off once the patient's stable, all information's been given, and everything's in order. So what role does the SRNA, the student, play, and how, and from one point to one point are they with the patient? Well, I am with the patient from the pre-op period all the way to the PACU period. So from the beginning to the end. You know, that's not to say that you're not being supervised, because there's always an anesthesiologist that's readily available, and anesthesiologists are almost always there during induction when you set everything up. So that's really how it works. But the SRNA student, you're expected to be there. There's no like, oh, I did induction, I can leave. You are there for the whole case, and that's really your expectations. If they have an issue as far as airway management in the ER or ICU, then they'll call anesthesia and we'll go on in. But usually your role is in the OR. All right. So I mean, that's just a few things I want to talk about. I don't want to extend this video with any more things, but I will do another video and just talk about MD, CRNA, care team model, because I have read some bashings on both sides, but you know what? I really feel like a team approach is the best approach, and I'll talk about that in another video. All right, guys. Goodbye.